Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, founder of Coaches Club, an author at philplisky.com, and a performance systems consultant in professional sports. Being a physical therapist and athletic trainer and strength and conditioning coach, we like to come at this from multiple angles. We want to present the latest research, the latest evidence, but most importantly, we want this to be practical for you so that you can implement this right away into your practice. I'm looking forward to today's topic, mental readiness for return to sport. I'm joined by Dr. Clare Ardern, who's an expert in assessing mental readiness for return to sport. She's an assistant professor in the Department of Physical Therapy at the University of British Columbia, Canada. Welcome to the podcast, Clare.
Thanks so much, Phil. It's great to join you and the listeners today.
Good deal. Well, could you get us started by just telling us a little bit about your background?
Sure. Well, as you and the listeners might hear from my accent, it's an Aussie one. So I started off in Australia with a PT degree and then PhD, looking at ACL injuries, recovery, and specifically focusing on return to sport and how to best support injured athletes to get back to their sport. And now 10 years later, or a bit more than 10 years later, I find myself in Canada. I got the travel bug after working a bit in Australia in research and then spent some time in the Middle East at the JOSPT Sports Medicine and Orthopedics Hospital, and then in Sweden at Linköping University and at Karolinska Institute in Stockholm, doing a lot of research, building on my PhD work, which was really very much around supporting that mental readiness to get back to sport. I've also had a pretty strong focus on evidence synthesis, so trying to help researchers do a better job at putting systematic reviews together and clinical practice guidelines, consensus statements, trying to improve the quality of those types of syntheses. The summaries that we all know when they're done well are really helpful because it saves you the time of having to go and read the many hundreds of articles that get published seemingly every week on a topic. And it's important that we know that we can trust those sorts of evidence syntheses. So my research career has had a few different tracks. I also am privileged to serve the international musculoskeletal rehabilitation and sports community as the editor-in-chief of Journal of Orthopedic and Sports Physical Therapy. So a few different hats, and it's a lot of fun.
You sure do a lot, and it makes me quite humbled as to what I do. Makes it seem like child's play. So I really appreciate it. Tell me about your initial interest, or what attracted you to sports medicine and rehabilitation, and doing all of this research in both clinical practice and summarizing the research.
Phil, I think like many of the listeners today, I probably had a pretty similar trajectory into sports medicine, and that is as a young athlete getting lots of injuries, getting interested in recovery, and then with originally a dream of going to the Olympics as an athlete and not quite making it, not being quite talented enough to get to that top level, thinking what were other ways to get involved in what seemed like a really exciting area of practice. And for me, PT was a logical place to go. I'd had lots of experience in the physical therapy room, and then ended up wanting to explore that as a career. So that it was a nice way to combine a lifelong love of sport and interest in injuries, and then ultimately wanting to help support athletes to get the best out of their body, stay healthy, and performing well. And my journey into research was a little bit the same. It was having an interest in serious knee injuries because, again, like many folks, I'd had a few myself and was interested in what we didn't know about that, and thinking about how could I contribute to improving what we did as clinicians. My research is very much embedded in clinical practice and trying to help clinicians help athletes. And so the research questions I study are very much driven by what's going on in clinical practice and what are the things that are coming up again and again in clinical practice. And that drove a real interest in trying to understand why it was that quite a few athletes, as many as 1 in 2, were not getting back to their pre-injury sport after an ACL reconstruction. And it seemed like it wasn't a physical problem for most of these athletes, that primarily they recovered really well. And for some reason, a lot of them were choosing not to go back to either their pre-injury sport, they might have changed sports, or they might have dropped down a level. So I was trying to understand why, and whether we were missing something as rehab professionals, recognizing also when I looked at my own training that we really didn't get much in the way of how to support psychology or the psychological or the mental side of recovery, and feeling like as an athlete myself, that was a really important part of recovery, and hearing from athletes that it was also really important to them. So I guess it was just blending all of those things, feeling like I could make a contribution, seeing that there was a gap, and then seeing that that there was something that was missing from our training. And on the evidence synthesis side, it was a little bit of the same, of getting frustrated as a clinician and as a researcher, reading syntheses that I felt didn't quite hit the mark or didn't quite help get over that next step of how do I get this into practice? What would it really look like in practice for me to implement these results? So then trying to work with guideline groups and with people doing consensus statements and people doing systematic reviews and meta-analyses to understand what we could do better as a sports medicine and performance and science community, and then trying to help support researchers to do that well.
Well, that's fantastic. I think it's so important to go back to that original passion, that original genesis, because it both helps us explain maybe the passion that we have. But I also think as providers, it's so important to go back to that, because your story is like a lot of people's story where, we were athletes and loved the competition, loved the camaraderie of a team and what that all brings. And I sometimes think we forget that going back when we just kind of get into our day-to-day grind. But that day-to-day grind is very similar to the athletic grind of knowing that what we do ultimately will produce a great outcome. So I want people to take away not only maybe just your research journey, but and your practice journey, but also maybe a little bit of a career path, and how do we stay engaged, and it's probably coming back to our why that way.
For sure. And I think the teamwork was definitely something that is something I continue to value as a researcher and certainly as a clinician. You're right, Phil, that whether you're the athlete in the team or you're the sports medicine professional who's working with the team, that sense of feeling like you're part of something bigger and supporting each other to get the best out of each other is a really motivating thing for me, for sure.
It's a big deal to me too. And that's actually why one of the reasons I love doing this podcast is because we get to have those discussions. It's not me up here presenting or just you presenting. We're having a discussion. How can we make this as clear as possible for people? So with that said, why do you think it's important to talk about this topic of mental readiness? And, we know why you got into it, but why is it important? What does it really matter to the people that we work with?
Well, I think it goes back to a couple of points I made earlier. One is that it's really important for athletes, and we know this because they tell us it's important. And the second part of this is that even when I speak to clinicians now who are graduating or have graduated in the last couple of years, and I teach in a PT program as well. And so when I look at different PT programs, it seems like we're still perhaps not doing as good a job as we could to integrate some of these principles into the musculoskeletal rehabilitation, sports rehabilitation degrees that maybe we need to best support athletes. And I get that that's really challenging for educators. I mean, there's only so much that you can squash into a degree program. So maybe it's something that if you're interested, then you start to pursue once you've graduated. But certainly when people ask athletes, they really want clinicians to speak with them about their mental readiness, their confidence, how they're feeling about returning to sport. And the flip side is that clinicians or sports practitioners feel like they don't have the skills to really have those conversations well or to do anything with the information. And it can feel awful, I think, when you get all of this information and feel a bit helpless to know, well, what do I do next? I don't really have the skills or the training. That's why I think it's really important. As rehab or as sports medicine professionals, we are usually the people who are seeing the athletes the most. So you've got a really privileged position of having a close, strong relationship often with the athlete. They trust you. They will talk with you about some of these things that are perhaps a bit making them vulnerable. And I think we have to really leverage that relationship in a positive way to bring about support and the best outcomes for athletes. So that's why I think it's so important.
Absolutely. Well, it is one of those things. We are in very unique positions. And if we go back to why we became a rehab professional, most of the time it is because we get to spend more time with our patients than maybe say other medical professionals, where it's 5 minutes every once a month or once every 3 months or once a year. We get to spend that time and develop that relationship. But that brings about both a very positive type of thing, but also maybe even more responsibility or a burden, or however you want to describe it, to have these difficult conversations, to have these open conversations more frequently. So what does the research tell us? Like, if we had to give, you probably could give an 8-hour presentation on all of this, but could you give us some highlights of the research in this area?
Sure. I think ultimately the research boils down to the mind matters when it comes to returning to sport. Simply having the physical capacity, having the strength, having the power, having all of the physical capacities to perform well in your sport does not automatically mean that the athlete is going to perform well in their sport. And now, over decades of research, we have really strong evidence to suggest that there is a strong relationship between the way that you feel and the way that you and your likelihood of returning to sport, and even perhaps the way that you as an athlete is performing once you go back to sport. So I think that's ultimately the why here. The other thing is that, as I mentioned before, athletes do really want this sort of support from clinicians or practitioners, and practitioners don't feel like, on the whole, they've got great skills to provide the support that athletes are looking for. I think we can all think of our mentor clinicians or people who sports rehab professionals who we look up to and think, oh, they just do a great job. And I think the outstanding clinicians, the outstanding rehab professionals do this without thinking about it. And the rest of us think, oh, if only.
Right.
So it's possible to do it. And if we can do it well, then there's good evidence to suggest that it's helpful for athletes. I think the one other thing that has becoming more apparent more recently, now that people are doing a lot more qualitative research in our research field, is that athletes want practitioners to speak with them about how they're feeling. I think certainly in my generation of graduates, it was very much I don't want to bring up fear, or I don't want to bring up the negative stuff because I might plant a seed that things are not so great for the athlete. When in fact, athletes will say now that they really want you to have those conversations, because if you're not opening that door for a conversation about fear of re-injury or psychological readiness, then it's almost like they're strange because they're feeling uncertain, or they're feeling anxious, or they're feeling fear about getting another injury. So I think there's a lot of really compelling reasons to do it, and the evidence is backing that up. Where we lack evidence still is on what are the best interventions to do to support athletes. And I'm happy to talk about some of the things where there's some preliminary evidence. We know a little bit from the sports psychology literature. And there are people who are working on different types of interventions, whether that's smartphone-delivered interventions or more mind-body interventions, or things delivered through a website. There's there is work going on in this space. It's challenging work to do, and I think that's probably why we haven't seen so many really well-structured interventions come to the forefront of what we can do as clinicians or as rehab professionals.
Well, you certainly just opened up a lot of different avenues right there in just a very short answer. One of the things I wanted to hit a little bit on that is maybe that positivity notion, where we as rehab providers in general, I would say, are pretty positive people. We are thought of as encouragers, and we want to give people hope. And so all of that just kind of goes into our nature of, whether that's a a self-selected process of people who go into rehabilitation tend to be a little more nurturing that way or not. But one of the things that the downside of that is if we're always positive and, oh, you're going to get back to 100%, everything is great, we, as you say, somewhat close the door to the conversation that I don't feel ready. I don't feel like this is it doesn't feel normal. Life doesn't feel normal. I don't know that I can handle it. And if you go generationally, like you spoke, where you said maybe in our generation as providers, we said stay away from that. But I'm finding that also today's athlete generation does want that connection and they do want to talk about things. What's your experience there?
It feels like a generation change, Phil. And sometimes I feel really old. And then
Right.
I find myself going, yeah, good on you. This is great that you feel that you can tap into this side of your psyche, if you like, and you feel much more comfortable and like it's a psychologically safe environment to speak about how you feel and that maybe it's not great all the time. And if it was great all the time, I'm equally worried, to be honest, because life is challenging and any sort of long rehabilitation, if we're talking about an ACL injury or shoulder stabilization surgery or whatever it is, there's ups and downs with that. So I think if we sugarcoat it and, as you say, we always bring the positive, then we're probably doing everyone a disservice as well, because this is hard and there are low times and there are more positive times in rehab. So I feel like that's really one of the starting points is, can you as a practitioner build a psychologically safe environment where the athlete feels like they can show some vulnerability and really tell you what's going on and how they're feeling. And that comes from you communicating well. Some of this is bringing in principles of shared decision making. And I'm often speaking with people who say, look, it's really hard to have a conversation with an athlete who's had 2 or 3 or 4 ACL reconstructions. And I really feel like maybe it's not a great idea to go back to this pivoting sport, to go back to basketball or to go back to soccer. How do I have that conversation? So I think it's about bringing your real authentic self to this, and in doing that, you're also giving athletes permission to bring their real authentic selves to that interaction. And then you're opening up a much more authentic channel for dialogue.
And part of my, whether it's a positive trait or a negative trait, I can't help but speak what I'm thinking or feeling. So that dialogue tends to go a little bit more naturally. But if we look at the communication science and the communication research in this, one technique that I've found particularly helpful, and I didn't know it was actually a technique, I just kind of did it, is called labeling. And that is, you can put it in the empathy category, you can put it into a lot of different categories. But in this scenario that you talked about of someone who has maybe torn their ACL 2 or 3 times or had serious knee injury 2 or 3 times, one of the things I think about at that point in time is I will say something to the effect of, wow, I can't imagine. I would be, really, really afraid to even think about going back. Do you have feelings like that? Or what do you, or are you, so you label it, say, it seems like it's a pretty scary thing at this point in time. And that, again, it actually opens the door by saying how they might feel, not certainty, but saying how they might feel allows them the door to go, no, I don't feel that way at all. I am so stoked to get back. I have no fear and I'm ready to go, which, by the way, might be a little bit more concerning than even the person who does have fear after 2 or 3, because maybe we have an unhealthy relationship with fear in that point in time. So you can use some of those communication principles and that communication science principles to really open that door.
Definitely. And again, we were talking earlier about not getting great training in a rehab professional degree, whether that's athletic training or PT or sports science, whatever it is. We're not getting good training in our degrees for really supporting athletes well from their psychological readiness or their mental readiness to go back to sport. I think communicating and some of these real skills is how Seth Godin speaks about them, that are good in our everyday life, in our family life, in our day-to-day work life, in our interactions with athletes. And so these are some skills that I've been really interested in as well around my research team. And I think the principles apply with whatever team you're working in. Can you create that psychologically safe environment? How would you go about doing that? How do you indicate to the person you're speaking with that where this is a safe place, you can be vulnerable, I'm not going to dismiss you, and you can open up in this space.
Absolutely. So as we continue thinking about that research, what are the other takeaways that you would say, all right, we definitely want, outstanding communication, which is more about listening. It's more about shared decision making. But what else?
I think for me, a lot of it comes back to, who are you doing this for? Is it for yourself or is it for the athlete? And that's the position I start from in shared decision making, because I think a lot of us think we're doing shared decision making because we've spoken with the athlete. We've said, well, what would you like to do? And then we proceed to very quickly get to a point where we tell the athlete what they should do. So shared decision making is not about doing what you would do if you were in the athlete's shoes. It's about you sharing information based on your experience, bringing the best of the evidence, bringing the best of your clinical skills and knowledge, and then letting the athlete make a supported decision. So it's not about just giving the athlete all the information and saying, okay, you go away and read it and then just tell me what you want to do later. It's about supporting the athlete to explore all of the reasonable options and then to come to a decision that's right for them. And sometimes the decision that the athlete feels is right for them is not the decision that you would have chosen if it was you, or not the decision that you would prefer the athlete to make. And we have to get comfortable with that. It doesn't mean you're a bad rehab provider or a bad clinician or you've done a bad job. It means that you have given the athlete space to make the decision that they feel is right for them, and you've recognized the athletes and honored the athlete's agency and capacity to make that decision. Let's put aside things like concussion and cardiac issues where these are in a different bucket.
These are medical
exactly.
decisions that have to be are different. Absolutely.
Exactly. So let's put those to one side. But primarily the sorts of rehab decisions that we're making with musculoskeletal injuries, I believe, are decisions that athletes can and should make, and should own those decisions with our support, not the other way around. And that's challenging.
Absolutely. Yeah, that is at the crux of it, right? We as rehab providers want to optimize everything. That's our whole goal. And to get the person back to where they were, even the foundations of your research are around the premise that not everybody's getting back to where they were beforehand. But even what you say there is maybe everybody doesn't want to get back to where they were beforehand, or do it in such a way that we think is best, or that, might be a different way of doing it.
Yeah. And it's challenging because people's motivations will change, people's goals will change. And again, this is why it comes back to those open, ongoing conversations, because if you have a discussion right at the beginning when you start working with an athlete and say, okay, let's set some goals. What do you want to do? What do you want to get back to? What's your return to sport goal? The goal that the athlete sets at that point in time may well have changed by 2 or 3 or 6 months later. And so if you're not listening, and if you're not having those conversations and creating space to have those conversations, and also creating the environment where the athlete feels safe to explore other options, because maybe I do want to change my sport. Maybe I'm not a professional athlete and I want to explore something else. Maybe now that I've thought about this, it is pretty risky for me to go back to soccer again. And I'm not that obsessed with soccer, and I would love to have a knee that functions well for the rest of my life. So let me try something else. So I think it's about creating the space to have those conversations, and then having the humility and the flexibility to bring the best of the research evidence. And we now have quite a lot of epidemiology evidence about who gets injured in what types of sports, and what is their likelihood of getting another injury if you go back to those types of sports. So at least bringing that information to the table so that you're supporting the athlete to make an informed return to sport decision, just like you would help them to make an informed decision about a treatment or about choosing surgery or not.
Absolutely. And I think we need to be better at leading people to those decisions. I, for example, don't downhill ski, never have since my ACL reconstruction. And not because I don't physically think I can. I do physically think, I just don't enjoy it enough that it's not worth the risk. And I love that you say that. Is someone needs to present that option to the athlete, and back to the labeling. Even if we present that option to say, hey, do you know that this is not something that you have to do? Maybe it's not worth the risk to you. That allows them the space to say, oh no, you don't understand. This is my plan for what I want to do, and this is part of it. It allows them to go down that road, or maybe allows them the little room that a parent or a coach or someone else hasn't given them the option of, oh, I didn't know that not playing was an option for me.
Yeah, exactly. Or I didn't know that there was this other sport that I really loved and now I've come across. Or equally, yeah, I know all the risks and I'm comfortable with that. And I absolutely love playing soccer so much, and nothing could stop me from going back. And I was that athlete, and I now live with pretty symptomatic post-traumatic knee osteoarthritis that limits what I can do now as an active person. And that really sucks. And if you'd asked me 5 years ago, before the symptoms started getting really bad, would you have done anything differently? Would you have gone back and kept playing soccer and kept getting those knee injuries? I would have said, yes, absolutely. There's just nothing that would have stopped me. I loved it so much. And now, knowing what I know about my knee and how it limits me, I'm not sure that I would have made those same decisions. So sometimes you just have to live with the consequences. But at least if you know realistically what to expect, you can hopefully make as well-informed decision as possible. We care about athletes so much, so we want them to stay healthy. We want them to perform well. We want them to do, excel in life and succeed at whatever they would like to do. And sometimes health and performing are at real opposite ends of that spectrum. And that's a tension, particularly in professional sport.
Oh, absolutely. For sure. We see that all the time. It's a different, that's an entirely different scenario. All right. So how do we see this playing out in the clinic? How do we actually do this? So the research is clear, but what does this look like in a therapy session?
There's many different ways. And I think maybe the best place to start, if you're thinking, oh, how do I have these conversations, or how do I just open up a conversation? I can't just walk in and go, so do you feel confident to go back to your sport today? Because that would seem really weird. And you're right, it would seem weird. So I think you've got to start from a position of having that strong relationship with the athlete. I think sometimes a questionnaire can help you get into those conversations. So if we use the example of ACL injury, the ACL return to sport after injury questionnaire was developed more than a decade ago to get at psychological readiness, emotions, fear, confidence, fear of re-injury. These types of things are the questions that are included in the ACL RSI. And so if you're asking athletes to fill in that questionnaire, then you could take the time to look at the individual responses to that questionnaire. And then it might show you that, hey, this person is really worried about going back to the scenario of where they got injured in the first place. So maybe then you can start to that conversation, to open up that conversation and say, hey, what is it that's really worrying you? And then it's a much easier way into that conversation, rather than walking in and assuming that you know what the athlete's concerned about, or expecting that they're concerned about going back into that injury-provoking scenario, when actually that's not the case at all. Maybe they're feeling fine about going back onto the pitch. They're worried about their contract, or they're worried about, exams at school, and that's the thing that's worrying them. So using the questionnaire is often a really nice place to start. And it doesn't mean you have to use the questionnaire all the time, but at least getting the information as a starting point to then open up those questions, and using your motivational interviewing skills to keep that conversation going.
I love that. One of the things, you did a great presentation, a great webinar on MedBridge with ACL return to sport and mental preparedness for that. And one of the things you talked about were these quicker check-ins as well, where rather than a full questionnaire has its place, right, to open up those conversations. Probably a great starting place, but may not be something that you're administering, let's say, weekly or something like that. A little questionnaire fatigue on that. And when we look at that, the idea, we also know that pretty clearly one of the risk factors for future injury after an injury is how well do you feel you have returned to function? How well compared to 100% normal are you? Kind of that sane score concept. We know that that's related to future injury. If we do that on a 0 to 100 scale and say, where are you at? How confident do you feel? How back to normal do you feel? Those types of things. Is that a good approach on that?
I like the quick check-ins like that. It's a little bit like you train athletes to do a rating of perceived exertion.
Mm-hmm.
And athletes get really good at doing their RPEs at every training
Right.
session. So it's almost like an RPE for any time you're doing a physical task. And for some athletes, getting to a new, more challenging task is really anxiety provoking. So you might have a simple question like, out of 0 to 10 or 0 to 100, however you do your visual analog scales, how confident do you feel about doing the direction change task or doing the agility test or going back onto the soccer pitch or back onto the basketball court? You can tailor that question to suit the scenario or the clinical context of the athlete. And that's why I think these questions are so helpful, is that it's quick. You can do these check-ins every session. You can train the athlete to do these sorts of 0 to 10 scores after their own training sessions. They can track, a bit like with an RPE, they can track their own recovery. You can see, where does confidence dip? And looking at that change over time can give you and the athlete a really nice, clear picture of, okay, whenever you start to get back into higher intensity training, or whenever training is starting to look like you're going to take more contact, that's when your confidence really drops. So what can we do together to help you feel much more confident in your own body? What is it do we need to work with the coach? What is it that we can do together to try to help you feel more confident, provided this is the goal that the athlete has? And I come back to, again, you've got to have these conversations. Don't assume that what you're thinking the athlete is interested in is truly what the athlete cares about. You've got to speak with them and figure out, what are the goals, what are they struggling with, and then what can you as a team work on to support them to achieve their goals.
I love that serial, continual, if you will, check in, because A, it opens up a conversation, but B, brings it a little bit more to awareness. One of my passions is return to sport testing and being systematic and kind of checklist manifesto, Atul Gawande type of concept. And I think where a lot of people go wrong with it is that they do discharge testing as these huge types of things. We're gonna do all the testing, and it's gonna be 6 months, and it's gonna be at 9 months, and yet I kind of purport the concept that we should be doing return to sport testing probably starting at about week 2 or 3, if we're, considering post-operatively or, depending on how severe the injury is, immediately, but that we're constantly doing that check-in, because it does a couple things. A, it allows us to know where we're at. It allows, in a long rehab process, the athlete to see the progress that they're making. And it also opens up conversations about compliance, or about, in this case, fear, or, lack of confidence. Those conversations can happen, and we can say, maybe your fear is based on your physical performance, not your, how you're thinking about it. Maybe your fear is a good protective mechanism that your body is employing because you don't have that stability in your knee.
Exactly. And we come back to this link between mind and body, and that it's really difficult to separate out the physical from the mental. So as you say, it's almost that check-in of, well, maybe that fear, that anxiety feeling is a signal that your body's not quite ready for whatever the thing is that you're thinking you would like to do. One of my favorite quotes is from Dr. Phil Glasgow, who's a professor in Ireland and a PT, has worked in the very top levels of professional sport for a long time, multiple Olympics, et cetera, et cetera. I could go on. He talks about rehab being training in the presence of injury. So you're not really doing anything different than the athlete would were they in their usual uninjured training setup. You're simply thinking about building up capacity in that injured tissue you're also training the rest of the body systems. It's not like you're going to just stop doing all of these other training. So I
Right.
love the training. Rehab is training in the presence of injury. And I think it's flipping that mindset, as you pointed out, Phil, flipping from we only do return to sport testing right at the time when I expect that you're going back to sport to no, we do return to sport testing every couple of weeks, because this is about monitoring and looking at how you're progressing, where you're at. It helps us to get a really good sense of where you're at and where we need to tweak the program.
And I think that second part of it is essential in there, of where we need to tweak the program, right? Because not only where you're at, but if you have it, just no doubt, if you're lacking quad strength, so certainly we need to do something to improve that quad strength. And we need to see if what we did actually improved quad strength. So we need to retest. But also when we're looking at this mental readiness, the concept of, by asking, I see where you're at, but then I also know, oh, you're worried about integrating back with your team. You feel isolated because you're no longer with your team. You're not practicing with the team. Well, shoot, I forgot. You can be doing everything with the team. You should be going to the 3 times a week lift, and you should be out at the practice field. And yeah, we've started jogging. So you should be doing, there's nothing in the warm up that is contraindicated for you. And maybe we can get back to some small sided drills, because we forgot, maybe it just didn't hit our radar. But if they're worried about it, man, that could cause us to actually intervene in a very healthy way.
Absolutely. And I think what you're talking about here are what I like to think of as simple strategies for supporting confidence for athletes to get back to sport. There's absolutely no reason why the athlete can't get back into the training environment if that's what they'd like to do. So what are you as a rehab professional doing to help facilitate that? And maybe it means you need to have a chat with the coach or the coaches to let them know where the athlete's up to, what she can do safely, what they might need to tweak, and get the athlete involved there too, because maybe there's some stuff that the athlete's not quite ready to do yet, but she can help out with some other drills, or she can help out with a junior team or whatever it is. So helping the athlete feel like, hey, I'm not this injured person who's no good to my team. I am part of this team. This athlete who I really identify as still exists.
Right.
Just because I've got an injury doesn't mean that I'm not an athlete. And certainly athletes can feel really demoralized and lose that sense of being an athlete when they're injured. So trying to help them stay connected where it's appropriate and safe, and letting the athlete guide a lot of those decisions is one of those really simple strategies for helping support confidence. And very much this is a mind-body connection thing. So you talked about quad strength earlier, and it might be that the athlete may not, if you ask the athlete, what do you think's going on there? Maybe they won't say, oh, I've got poor quad strength, but it might be like, I just feel my knee's really unstable, or I feel like if I jump off this high box, my knee's going to collapse underneath me. And with your clinician hat on, you can go, okay, I think part of this is about quad strength. So let's do some really heavy work on quad strength. And then let's see how confident you feel about this, single leg squat, or this jump, or whatever it is that the athlete is feeling anxious about.
That's amazing, because if we look at this in terms of, I always use, and again, it's probably checklist manifesto driven, but I always use the flight analogy, the cockpit analogy, with all the gauges in there. And if we are systematically looking at all the gauges, then we can know the interplay of the gauges. And I think that's an important concept, where we may not be looking at the mental readiness gauge as often as we should, or in the way that we should, and looking at it in comparison to all the other gauges. Again, very simplistic example. I'm lacking full knee hyperextension equal to the other side, and I'm lacking quad strength, and my mental readiness gauge is down. Now we have a conversation and said, it seems like you're not feeling fully ready, a little bit apprehensive or nervous about doing these type of activities. Yes, you're right, I am. Well, the good news is I've identified these other gauges over here that probably caused us to understand why you're feeling that way. There is a physical reason that you're feeling that way, and that's perfectly normal. So when I'm asking you to do this X, Y, or Z intervention, that's why it is. It's to help you go down that road.
Definitely. And the other point that I think is important to make here is that we're not talking about making a mental health diagnosis. And certainly we know from the research that anxiety, depression, clinical anxiety disorders are relatively prevalent in athletes. There's no reason to expect that an injured athlete would not have the same prevalence. So being on the lookout for some of those sorts of things is important, and making that early referral as you see it's appropriate. So none of the strategies we're talking about here are going to deal with a clinical depression or a generalized anxiety disorder. That's something that's appropriate for referring to family physician and getting some psychology support. So speak with your colleagues, and that's where working in an interdisciplinary team is really helpful, because you can tap into those people and say, hey, I'm concerned about this athlete for these reasons. Here's what I've seen. What do you reckon? Is now an appropriate time for a referral? And I know for some people you're working in solo practice, and I think in that case it's about making sure that you've got strong referral networks and you can go to the psychology help or the psychiatry or the family physician as appropriate, or back to the sports medicine physician as appropriate. So we're not trying to solve mental health diagnoses specifically. We're talking about supporting athletes to feel much more mentally ready to go back to sport. There's an important distinction.
Absolutely. That clarification is really essential. Almost like, that even with an athletic population, that we're testing blood pressure and heart rate and things like that, not because it may be related to their current diagnosis, but just because it's a risk factor and it's prevalent. Mental health diagnosis is a separate but equally important aspect of this, and we shouldn't just necessarily confuse the two. And I think as soon as you say psychological readiness or, mental readiness, it can be put into a mental health diagnosis bucket and cause people to shy away from it. No, we're talking combining the mental readiness with physical readiness and still monitoring for mental health, just like we would any patient. That's awesome.
Exactly. And knowing your population as well. So if you work with a lot of high school and college athletes, recognizing that there's peak times around exams, or what are the really stressful times. Maybe this kid's just left home for the first time. That's really stressful. So knowing what's going on in their life will also help you build up that picture and make a decision about whether you need to refer on, or whether this is something that's appropriate within your scope of practice to manage.
Oh, that's awesome. Well, can we take go into some maybe specific examples of how to use this in a clinic? Let's go through some case scenarios.
Okay. So imagine 19-year-old Sarah. She's an amateur handball player, and she's got a non-contact ACL injury. For the first couple of months, she did some rehab with a PT. Things were going well. She was back in the gym doing some pretty heavy strength training until she had some dynamic instability. Her knee gave way, and that was a pretty serious, scary thing that happened. And then she, in collaboration with the PT and surgeon, decided that because she really wanted to get back to handball, ACL reconstruction was her best option for treating this instability. So she had surgery, started PT, first 3 months went really well, and then she was moving away to go to school, changing cities, changing PTs. She was at university, so not earning a ton of money, and it was pretty expensive to go and pay for PT. So she decided she'd do her own PT for a while. So she's doing her own strength program, running program for the next few months. And then at 6 months, she presents to your clinic. So she's come to see you for the first time. She's been doing this strength and running program, hasn't done any sort of hopping or direction changes, because that was the really anxiety-provoking thing from way back when, before her surgery. So then I guess the question is, if she's asking for return to sport advice today, what do you tell her, and what do you want to know right now? What sorts of things would you measure? And I think in speaking with many people, you do want to get a sense of what's going on in her knee. How well is her knee tolerating load? And you might look at things like swelling, range of motion. You might ask her about hopping, why she hasn't been able to do any hopping. You might want to look at some single leg squat or a lunge or stair climbing to look at her dynamic control of her knee. You might also do a 30-second single leg sit stand test to get a sense of her quad endurance. You might also at this point use the ACL return to sport after injury scale we talked about earlier. So this point I think is really about getting a sense of where is her knee function at right now? Where is her mental readiness? And I think I would also want to speak with Sarah about what does she expect? What are her goals? Where does she think her knee is at right now? Because if she's saying, oh, look, I think my knee's great, I can go back to full contact handball tomorrow without any issues, that might not fit with your the clinical picture that you've just measured. Where equally, she might on the other side say, look, I don't think there's any chance I could ever go back to sport. My knee's just terrible. It doesn't matter what I do. I can't get strong. I'm really scared. I don't know how this is going to work. And so then it's a different conversation about, well, is getting back to handball your true goal here? Mm-hmm. Have you thought about other sports? So it opens up those other conversations that we talked about earlier, Phil. So I think at that first stage, it's getting a sense of physically where is she at. You could use, I think it's appropriate to use a questionnaire at that point to get a fairly standard measure, a baseline measure of where she's at from a mental readiness side of things. And then that gives you a whole lot more information along with talking with Sarah to figure out where do we go next? Is this a much more physical focus? Is it a much more mental focus? Do we need to combine the two sides? Probably yes. How do we tailor this to Sarah's goals? And that's going to dictate then some of the next things that you do.
So with that patient in particular, if we look at, I like the idea of that questionnaire, then to kind of establish both a baseline and an opening point for talking, because as we marry the physical function with the mental readiness, we get a better picture of what's going on. But how do we look at that? One of the things I've heard you discuss before is that there isn't a number that we're looking for. There, we know, for example, in the SANE score, we can say above 92% is probably a good indicator. But even that, we probably know that doesn't even have a ton of face validity of what's magical about 92%. Well, it's probably better to be 100% than it is to be 92, but we should probably at least be 92. Talk more about what is that number, or how do we interpret the numerical values of these questionnaires?
This is a real challenge, I think. And one of the things I regret from my PhD was that we calculated a cutoff score for the ACL RSI. And so it magically became that 57 was the point at which you were either mentally ready or not to go back to sport.
Absolutely. And 56 is completely unmentally ready, and 58 means you're just doing great.
Exactly. So this is the problem whenever we're trying to take a number that represents a very complex construct in psychological readiness and distill it into a binary yes or no, you're ready or not ready to go back. So in many ways, I would love to just get rid of the numbers, disregard the absolute number, and marry the information with the information you gather from your clinical assessment and the information that you gather from listening to the athlete. And that might take you a couple of sessions just to gather all of this information, because you might really need to do a lot of talking with this athlete to find out where Sarah's at, what are her goals, what does she expect is going to happen, what has happened before, how stuck in her psyche is that giving way episode? Because for some athletes, as you know, Phil, that it's that one event that's really stuck in their mind, and it's very challenging to get over. And again, that might help you make a decision to say, look, I think it's really helpful. It's going to be helpful for you to speak with a sports psychologist to get some professional support to get over that thing that's really embedded in your mind. So that's why I say the number is in some ways meaningless. It gives you a baseline to start with Sarah when you start to reassess. There are some studies that have looked at the minimal important difference or the minimal clinically important difference. How much do you need to see a change in the ACL RSI the challenge is that different clinical populations have different MCIDs.
Mm-hmm.
So I think there's a lot of work that we as researchers need to do to support rehab providers and practitioners to get a better sense of what are these questionnaires truly telling us. And until we have that information, I think looking at the underlying scores to the questions is probably going to give you a lot more information from something like the ACL-RSI, because it will give you a sense of, is this really a fear issue? You can look at the questions that are specifically asking about fear, or is this more about emotions, or is this more about how the athlete's assessing the potential risk? And that might then dictate what you do from here and how you speak with the athlete about what's going on and what to do next. So it's tough, because having a cutoff number helps you, I think, have a decision heuristic. We all like to have those heuristics that can help us make a quick decision. But I think in this case, it's too complex a phenomena that we're measuring to easily say, well, if you're above 65, you're fine. And I think we also, at the very start, we talked about how maybe having a bit of fear or a bit of apprehension about going back to your sport is a good thing. And I do believe that. The people who fly through and feel not scared at all, they're just,
they're
it's almost
invincible.
like, yeah, exactly. They're invincible. And it's almost like you think, do you really know that, do you really understand what it is that you're doing and that there is a risk that you could get injured again? So I'm equally concerned about the two ends of the spectrum, of the person who is so anxious that it really prohibits them from doing what they want to do, and equally the person who's just so blasé, who maybe doesn't have a good understanding of what the risks are.
That's incredible. So when I think then about questionnaires, to summarize that, questionnaires are, number one, a great communication starting point, meaning it allows us to ask tell me more about the way you answered this question. Tell me more about that. And, oh, well, I answered that because, okay, which we don't then know. We could be anything, right? So it's communication, but then it's also to understand it, as we look at the gauge, the different categories of mental readiness, to say this is probably more in this category or that category. And when I'm doing my physical interventions, which I know are likely low, that maybe I can even talk to the person about why we're doing this. And this physical intervention is here, which, as you've indicated on this questionnaire, that should help that, because as this number gets better here physically, which we know we can rely on, which we know it can give us a lot of great information, this over here should help. This should help the fear part of this. And then when we re-administer the questionnaire, then we will know, did we actually address that or not? Because physical function may have normalized, but the fear didn't. And so now we know, okay, well, we have a psychological readiness problem that is beyond our scope, because we have fixed everything physically and we've identified that. I love that use of questionnaires there. All right. So talking maximum impact, what would your 3 top takeaways be that we can action right away in practice?
All right. 3 things. Practice shared decision-making. Get comfortable practicing shared decision-making. And as we talked about before, that sometimes means that it's going to feel uncomfortable. And it should feel uncomfortable, because it's about relinquishing control from your perspective as a rehab provider, and giving that sense of control and autonomy to the athlete. Not to make a decision by themselves and without any support, to make the decision that's right for them and acknowledge that they are the best person to make that decision. So shared decision-making is one. Decide which questionnaire or questionnaires do you like to use, do you feel comfortable, and that work well in your practice. There's a few different questionnaires. We've talked mostly about the ACL Return to Sport After Injury questionnaire today. That's great if you work with athletes with ACL injuries. It has been adapted to other injuries, post-shoulder stabilization, hip surgery, hip arthroscopy. So there are a few different options out there if you like those sorts of questionnaires. There's more generic questionnaires about re-injury anxiety and about confidence. So you might have to do a bit of looking around and figuring out what fits well with the athlete population you work with. And then my final message is, have a flexible approach. Take a flexible approach. Really listen to the athlete. listen to what they're saying and what they're having trouble with, and then act. Don't do it the other way around, because if you're acting without listening, then you have no idea whether what you're trying to do is really what the athlete is going to care about or is going to have maximum impact for the athlete.
Oh, those are awesome takeaways. And I just really believe this episode has given people to understanding, hopefully, A, that they should be looking at this gauge, and B, how to interpret it and how to put it in context of all the other gauges that they're using. So to wrap things up, would you tell us a little bit about what you're currently working on?
Yeah, sure, Phil. I'd love to. My main research work is a little bit of a sidestep away from the sports medicine world. I'm still involved in sports medicine. The research I lead, though, is looking at advanced practice musculoskeletal care. So how can we leverage the great reservoir of skills that PTs have in musculoskeletal primary care to try to help more people get access to primary musculoskeletal healthcare? It's a big challenge for people to get access to primary care in Canada, as I know it is in many parts of the world. So we're working on different models of care, different ways of accessing PT or musculoskeletal care more broadly, and working with the community of patients, of clinicians, of health policymakers to co-design solutions, digital health solutions that will work best for communities to help them get access to the best quality musculoskeletal care that's available.
Well, once again, I'm feeling very tired by all the different things that you're doing. That's amazing and meaningful work. So that's great. I had mentioned your MedBridge course on basically a deeper dive into mental readiness, particularly with ACL reconstruction. So that's a great course on MedBridge that I would highly recommend. But how else can people connect with you?
LinkedIn is a good way. I am definitely available and happy to connect with people on LinkedIn. My email address is also, if you go to the JOSPT website, you'll be able to connect with me via email if you've got a specific question about research or about some of the research work that we're doing. Or if you Google UBC PT department, you'll find my research profile on the UBC Physical Therapy Department's website.
Fantastic. If you'd like to connect with me or find out what I'm working on or what I'm learning, you can do that at philplisky.com. Clare, this has been amazing. I feel like we could just continue this conversation for hours, and I hope sometime in the future we can.
I'd love that. Thanks, Phil. Thanks for the opportunity, and lovely to chat with listeners today.
Good deal. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com. See you next time.